thank you very much for the invite, Vivian, and thank you very much for asking me to come and talk to you all. I'll probably stay behind the microphone for the moment because this is being recorded, and that will be okay, but then it'll sort of be more interactive at the end when we answer questions and go over things. So, as Debbie says, I've had a long experience of TSC. So we all have to declare our interest, doctors, when we talk about various things, and this is my interest, is my daughter, Lauren. And she has TSC. She's moderately affected. She has, she has learning impairment and some autistic spectrum disorder and resistant epilepsy, and she lives at home with us. But she's very sparky and pretty intelligent and a wonderful person to be around. So, TSC. As you know, various aspects. This is a graph from Paolo Curatello from his paper in The Lancet, where he was trying to plot out the timeline of various problems in TSC, and I'm going to come back to this theme. I've been asked to talk about advances in kidneys and diagnosis, surveillance, management. I was going to make it slightly broader than that, because there's some very exciting other things going on, which I think would be good for you to know about. So as you see, the kidneys, so the problems start to become apparent within the first few years of life, but what happens, we think, is the AMLs and other kidney lesions, like other TS problems, form when in the womb and in utero, when the baby is forming. But they just, when someone's born, their AMLs are microscopic, and they just grow as the kidneys grow. And the first signs of, I'll just explain, this is the UK TSA new logo, and I've stuck it on a few of the slides because some of this I've already talked about and had a practice run at the TSA AGM, just to make sure I get it right for you. So when someone's newly born, the first things that are obvious are that the heart tumours, the rhabdomyomas, they're usually not too much of a problem for most people because they shrink very fast. Sometimes they can cause significant problems in infancy because they can cause blockage. And they can lead to abnormal heart rhythms, either then or later. So, everyone with TSC needs an ECG at some time, particularly if they're going to have an operation. They need to have their heart rhythm checked. The next main issue are infantile spasms, which affect at least 60% of people with TSC, and are very important, we know now, because infantile spasms, unless you control them very fast, cause lots of problems with they cause resistant epilepsy, and they cause intellectual impairment, and they cause autism if you don't get control of them. And we know that because there have been some early intervention studies targeting infantile spasms that have made a big difference, which I'll come back to. They're up there. So Professor Wozniak and Professor Curatello in Rome have both done studies where they've watched people who've been born with TSC, usually diagnosed using a fetal ultrasound, when you can pick up the cardiac rhabdomyomas in about 20-30% of people. So that's what they've got. And they've counselled the parents, watched them very closely. Professor Wozniak was doing EEGs on people from the day they were born, really to pick up the seizures, the infantile spasms, before they start, or the day they start, and then putting them on vigabatrin the day they start. And that meant that instead of two-thirds of those people having, those children born with TS having intellectual impairment, only one-third did. And instead of one-third having profound intellectual impairment, none did. And the same improvement in epilepsy. So it's and they've both published those papers now. And the next trial to look at that is being designed. That's very exciting. The next trial will include an mTOR inhibitor, because starting in that age group may stop epilepsy completely. It certainly does in animal models. So that's something, again, we'll come back to early intervention studies. And you'll know that white patches people are born with, and that's one way of diagnosing TSC, if you've got 3 or more white patches. And so, in terms of progress, I can't quite see this. Will I still be on the video over here? Good. In terms of progress we've made, the genes in 1991 and 97, 91 TSC2 was cloned and 97 TSC1. And by cloned, that means identified, and the sequence was read, so you could make the protein that it makes. And so we knew what the proteins were, but it was 5 or 6 years before we had any idea what they did in the cell. But once we'd identified that, we knew that they specifically controlled the mTOR pathway. And I'll explain the mTOR pathway in more detail in a moment. Other major things in terms of progress have been a growing international collaboration of physicians in terms of working out what's going on, what to do, and writing guidelines. And you'll know that the new international guidelines have now been published. And I checked on your website, you can get to them, and you can download the actual papers. They're open access. That means you can print them out and you can give them to anyone you like, and there's no copyright. And that was the condition of putting them in the journal they're in. So feel free to download them and take them onto your physician, even. And other epidemiology studies. So we started this new epidemiology study, TOSCA, which our Italian colleagues thought up the acronym. Our Northern European colleagues wanted to call it rectum. Which did stand for something respectable, but we vetoed it. So TOSCA, there have been lots of small observational studies and snapshot, but the biggest collection of observations on people with TSC is about 300 subjects, and that's really not enough to tell exactly what's going on. TOSCA is a research study, and it's designed to enroll 2,000 people, 2,000 to 2,500 people worldwide with TS, and very precisely document what the problems are, and what happens, and then follow them up over a period of time. And Australia has joined TOSCA. The TOSCA Centre here is centred on Sydney at the moment. And it's funded as a research project, so that means it's viable and will keep going. And that, I think, is going to bring out some very useful information. And part of the tracking is people on treatment, everolimus treatment or any other treatment, will also be tracked and see how effective the treatment is. And one of the main things we're leading up to is looking at starting effective treatment very early to prevent most of the problems. But to do that, we need to know what the problems are, how common they are, whether you can pick out people who are at most risk, and also whether there are any side effects from the treatment, either medium or long term. So, onto the kidneys for a bit. So I'm an adult nephrologist, kidney specialist, but I've also trained in paediatric nephrology. And when I work at a multidisciplinary TS clinic at St George's, I do both. We follow about 150 patients at St George's. So what we know about TS is the most common problem are the angiomyolipoma, these sorts of small, fatty, benign tumours that are there when you're born and just grow bigger and at different levels in different people. We know that there's a risk as these get bigger that they may bleed, and they can bleed catastrophically. And the risk is probably nearer 50% than 25% over a lifetime. So that's quite common. We know that some of the cells from the AMLs break off, circulate in the blood, and can seed into the lung, and they cause LAM. And that happens in a small percentage of men, but in men it doesn't seem to cause problems. But it also happens to most women with TS. And by the time, the latest evidence is that by the time people are 40, 80% of women have some evidence of LAM on a high-resolution CT scan in their lung. Now, it's only about 5 to 10% of women with LAM get progressive damage and disruption of their lung failure. So it is, again, another significant problem for adults. Kidney cancer, mainly renal cell carcinoma, does occur in TS and is commoner than the general population, and it occurs in children and it can occur on both sides. Luckily, thankfully, not too common. And if you're keeping someone's kidneys under surveillance, you can pick it up, and it's like kidney cancer in people without TS. It's very slow growing, it metastasizes very late, so you've got months or a year or two to deal with it before it causes any real problems, so long as you're looking for it. Polycystic kidney disease, I don't know if you know of that, but 5% of people with TS also have polycystic kidney disease. The gene that causes polycystic kidney disease is on the tip of chromosome 16, right next door to TSC2. And those 5% have a deletion across both genes, and they get both problems. But in TS, the TS makes the polycystic kidney disease worse much quicker. So that normally, if you just have polycystic kidney disease and no TS, you've got a risk, 30-40% risk of going to kidney failure when you're 50 or 60. In TS, the risk is far higher, and then renal failure occurs in teens or 20s. So half the people in kidney failure in TS, it's due to polycystic kidney disease.
And the genetic deletion that you just mentioned there, is that a high correlation or a low correlation between its presence and the probability of PKD?
Right. No. So if you've got true PKD as well as TS, every single person's got that deletion across both genes.
So on the genetic signature, the deletion was there, then and you detected that through genetic testing, then you'd be able to predict the onset of PKD.
Yes, absolutely. One of the difficulties, though, is that 20-30% of people with TS also have simple cysts. And simple cysts we think don't cause any problems, but they may be multiple on both kidneys. And they can be quite hard in the younger people to tell the difference between that and PKD. And the only real ways to tell really are if you can identify the genetic mutation, and if it's not the PKD one, then the simple cysts are not PKD. And if someone's got premature kidney failure or high blood pressure in childhood, then that's almost certainly PKD and not simple cysts. A couple of studies that we've done show that about 1% of people with TSC are on dialysis. I think the number who need dialysis is likely to be more than that, but not everyone gets referred by it, and not everyone wants to have it. What we now know, and I'm going to show you some of the results, is that reduced kidney function is much commoner than that in TSC as people get older. And that's one of the main problems for adults with TSC. That means that high blood pressure is going to be much commoner as well, but no one's properly surveyed high blood pressure, but it is a crucial thing to check regularly in someone with TSC. So that's just a picture of LAM. As I say, the symptoms are rare, but it does occur to most in most women with TSC. And treatment of AMLs, up till recently, the standard treatment, standard care has been embolization for AMLs that are acutely bleeding, or more latterly, AMLs that are progressively getting bigger that we think are going to therefore bleed, and we want to treat preemptively before bleeding. Old treatments such as surgery, cryotherapy, radioablation, ways of frying the AMLs can still be used occasionally when you can't embolize something. But the big change has been the use of mTOR inhibitors for preemptive treatment. But what are the questions? If you're going to follow someone's progress of kidney disease and try and treat things, stop things before they happen, how much benefit will you get from that, and what's the risk of doing it, and does the benefit outweigh the risk? And then the second, of course, is what is the best treatment preemptively. So I'm going to show you a number of slides. I want to go into that. This is our patients from our clinic at St George's. This is their largest AML, and this is the diameter of the largest AML in centimetres, plotted against age. And as you can see, there's a tendency for the AMLs to get bigger as people get older. But there's a big scatter. And what happens? This is same patients, not quite as many because you don't have long enough data on some. And this is the growth rate in millimetres per year of AMLs against age. And the first thing you can see here is these patients along the baseline here, they're about a third of adult patients, their AMLs aren't growing at all. But 2/3 are still growing, albeit slowly, and so they would be at risk. And then there's a growth spurt in the late teens, early 20s, and that's often when most of the problems occur. They can occur later, but they often occur younger. So we looked at what we could do to pick out who would be most likely to get into trouble and who we would target for treatment. And besides the clinic at St George's, we've been running a registry through Brighton, a research registry for people with TSC and kidney problems. And these are a group of those patients. And in here, we've plotted AML size against age, again of the largest AML. And in the pink squares are the people who've had bleeds, and the blue diamonds are people who haven't. And as you can see, there's a tendency here for the people whose AMLs to have grown biggest, fastest to bleed. But there's a complete scatter, and there's no distinct cut-off in either size or age. There is a cut-off of sorts here in that almost all the AMLs that are bled are larger than 3 centimetres. So the ones that are less than 3 centimetres have much less chance of bleeding. And that they still can. And earlier this week I heard about someone with a 1 centimetre AML that had a major bleed in Australia. But it's rare. So a subgroup of those patients, we've now got data on following over 9.5 years, 54 patients, and we've divided them into the 2/3 whose AMLs are growing and the 1/3 whose AMLs aren't. And most of the bleeds occur in the 2/3 whose AMLs are growing. Only 2 people had bleeding if their AMLs weren't growing. And one of those episodes of bleeding I don't think was from their AML, I think it was from their bladder. So there's a distinct cut-off. The continued growth of AML does mean you're at risk of bleeding. And statistically that's significant. And with these sorts of figures, you can work out what we call a number needed to treat in medicine. So you can work out the absolute risk ratio of growth, no growth. And that tells you how many people you need to treat preemptively to stop one bleed. It turns out to be 3.2. That's without using a size cut-off. So, of course, if you're just going to target people with AMLs bigger than 3 centimetres who are still growing, with the people most at risk, that would be, then you probably only need to treat 2.5 people to prevent one bleed over 10 years, and over a lifetime it will be less. So we can kind of predict who are the people at risk. And so when we rewrote the international guidelines, that's what we put in, that people with AMLs that were 3 centimetres or larger and growing should have preemptive treatment. And then I'd just like to talk about reduced kidney function, because when it was apparent, we had a number of hints that there were people with reduced kidney function, some of it due to interventions, embolization or surgery, but it wasn't quite clear. And even in the literature, when we wrote the last lot of guidelines, we did a systematic search for every paper that had been published for the previous 22 years that was about people with TSC, and analysed all the results in every subject. And there were some bits on chronic kidney failure, but no really good data. That Brighton renal registry I was telling you about, we've divided our patients into those who've had bleeding and those who haven't. This is their mean age. So the ones who've had bleeding from our registry, the mean age is 34, but there's quite a scatter from young childhood to elderly. And then mean age of the ones who haven't had bleeding is somewhat younger. And this is their GFR. So GFR is a way of measuring kidney function. A GFR of 80 or above is normal. So these are people who've had bleeding, already had a slightly reduced kidney function, which was worse after they'd had their bleed and intervention. And that's not a surprise, because if you have severe bleeding, you can get acute kidney damage from having low blood pressure and being shocked. And then you have either surgery or embolization, which may take out bits of normal kidney as well as the AML, which would leave you with impaired kidney function. The major kind of shock and worry was this, in this, again, young age group, who had normal kidney function on average, but a range, and then by the end of the period of observation, quite a lot had impaired. The mean kidney function was much more impaired, and although some were normal, some were very low. And these are people who've got multiple bilateral AMLs, but have not had any intervention, have not had any bleeding. So it certainly looks as if AMLs cause kidney impairment on their own. And this is a system of classification of AMLs, and this is, just to see if I taken from Bernard Sonnenberg. So Professor Sonnenberg has been following up 350 patients in his adult TS clinic in Holland, and he runs the only adult TS clinic in Holland. And he's been following up for more than 18 years, and he's just analysed all his results. He classified the results, classified the AML burden according to this thing, which is probably something that's going to become an international way of doing it. From level 0, which is no AMLs or only one, smaller than 1 centimetre, up to 3, which is up to 5 AMLs, the largest one being 3.5 centimetres or bigger, and then more involvement in more AMLs and bigger AMLs after that. And there's 34% of his patients, by the time they'd been followed for 18 years as adults, had very severe AML involvement of the kidneys. And what he found was that there were some events, some episodes of bleeding and needing dialysis in these groups, but almost all the problems occurred in people with the worst disease. And those problems are very common. Almost every patient had either a bleed or needed dialysis or a transplant, etc. So treating AMLs prophylactically to stop them getting to this stage is going to be a major target of monitoring, surveillance, and looking after people. So what treatment? As part of the guidelines, we analysed all the papers that reported embolizations. There weren't that many that were good, but these two are them, with enough data to work out what was going on. So this is all we want to find, and that's only depending on what diagnostic criteria you used for TSC. About 60 to 76 people with TSC had an embolization. The follow-up was quite short, up to 4 years, or 5 years, 4.8. And the recurrence rate was about 20%. So about 20% of people within the first 5 years of AML had regrown to the original size or bled again. So it's a good temporary treatment, but it doesn't long-term solve the problem. Now that's a big AML with a huge, great blood supply on a young lady who was referred to us from Northern Ireland, and we embolised that AML, and because prophylactically, we felt that she was at high risk of having a bleed, and it would be catastrophic if she did.
Sorry, embolised meaning?
Oh, sorry, yes. So embolised. So we put a plastic tube in the femoral artery in the groin, threaded it up to the kidney, and this is the tube going up, down into the kidney and along the artery that was feeding the AML, and then injected coils down, which blocked off the blood supply and killed off the AML. And that's that's particularly useful treatment if you're having an acute bleed, because as you inject the dye, you can see the vessel it's coming out of. You can inject the coils into that vessel and just stops it bleeding. So it's a good rescue therapy. When you're trying to control or destroy an AML, there's a balance to be had between completely blocking off the blood supply, which may take out a bit of surrounding normal kidney tissue and thus impair the kidney function, or just destroying most of it, which will spare the normal kidney tissue, but means that the edge is still alive and may then regrow, because some of the blood supply is attracted from the outside, from the edge inwards, as well as just through the central vessel. So that's a kind of conundrum. I'll come back to her story a bit later on. This is another lady who's now 38, who's referred to me, and she's got these are the kidneys, but they don't look like normal kidneys at all. They're massive because they're completely replaced by AMLs and hugely expanded. She had LAM, and she had a rash, and she had some minor focal seizures. She didn't have a diagnosis of TS. She was referred, because she had anemia, to a local physician who investigating this and renal and kidney impairment. Obviously knew what it was and sent it straight on to me. So that was the first diagnosis of TS that she had. And she brought a son who had facial rash and seizures and quite significant autism and intellectual impairment, and he didn't have a diagnosis either. So you see that some people do present very late. So embolisation is not really going to be of any use to her. What we need is some more systemic treatment. This is our old TS logo, and this is what a professor of paediatric neurology told Anne Carter and Tom Carter. I don't know if anyone know them, but they're a couple of the founders of the UK TSA. So they went down from Nottingham to London to see the big prof when their daughter Sally was 3 years old, and she's now 35. And asked, after he told them all about TS, what's going on in research? And he said, there's no point. So they went home and they raised £1 million for research, and kick-starting the research in the UK. On the basis, and also putting money into TSA, the TSA, like the ATSS, would provide care for today and some hope for tomorrow. But we've gone beyond the hope for tomorrow now, actually, because we've made stunning progress that we didn't expect to make so fast. As I say, the genes were discovered, and then it was a long while before we tried to work out what they did, and this, it turns out, is what the tuberine and Hamartin do. It was discovered by fruit fly geneticists. I don't know, those of you who are not scientists, there's a whole group of ivory tower geneticists who do nothing but live in the lab, and they experiment on fruit flies. Fruit flies, because they breed very fast, and no one minds you experimenting on them. And because molecular processes in cells are conserved throughout evolution, so all animals have very similar processes. So if you find something out of a fruit fly, it applies to man. So that's and also often to plants. So they discovered the GIG gene, which was controlled the mTOR pathway, and the GIG gene is really the TSC2 gene. It's slightly different in a fruit fly, but most of the sequence is exactly the same. So one conference, our geneticists found their paper and then disappeared for half a day, obsessively searching the internet for everything else they could find on this subject. Came back in the evening saying, we know how TSC works. It's mainly, we think it's this. We think it's the mTOR pathway that goes wrong. And that's exactly, as subsequently, that's found it may not be the 100% of the story, but it's about 90% of it. And TSC1, TSC2 genes make this protein complex that sits on the mTOR switch and turns it off. When, from outside the cell, there's a signal that the cell needs to grow and divide, there's called a phosphorylation cascade that breaks up that complex, switch is turned on, and then the protein, the cell starts to make protein, it starts to get bigger, and then as it gets bigger it divides, and then each of those cells get bigger and divide until that switch is turned off again. And in a normal cell, as soon as the growth promoted from the outside, the cytokine as it's called, goes, the switch turns off. But in a TS cell, either TSC1 or TSC2, both copies are mutated, and it can't turn off, so it keeps on going. And when it can't turn off, the cells keep growing, keep dividing. They may stabilise for a while, there's always a risk that they'll start to divide again. And they don't specialise into normal cells, they don't go to the right place in the organ, and they don't die. And the not dying is important because normal tissues, the cells, are programmed so they die when they're not needed. So that's an issue, but the very exciting thing, and I'll just go, so in someone who's born from a parent with TSC, they'll have a mutation of either TSC1 or TSC2 in every cell in their body. But they can be perfectly okay providing the other gene, because every cell has two genes, providing the other gene is okay. But unfortunately, during fetal life, as the fetus, embryo and fetus is growing, the genes are vulnerable. And if you've got one gene mutated in a cell, then the other can be damaged. And then every cell in which that occurs, that cell turns into a TS cell and later into TS tissue. So the people are born as a mosaic with a number of cells scattered throughout the body, throughout their organs, that are TS cells, and then not have other normal cells. And then in later life, some of the normal cells, if they've got one TS gene damaged, as they develop or grow, they can become TS cells as well. So there's that continuing risk. And part of the reason that people with TS are so different from each other is that the number of those second hits and the number of TS cells they have varies from person to person. The very exciting thing was this. mTOR stands for mammalian target of rapamycin. Rapamycin is sirolimus. Rapamycin is so-called because it was discovered on Rapa Nui, or Easter Island. And people have been around the world growing fungi, and they're looking for antibiotics. And fungi have to secrete antibiotics to stay alive, to kill all the nearby bacteria. Otherwise, bacteria will attack them. So they're a very good source of new antibiotics. And rapamycin, or sirolimus as it's now called, was thought might be a good antibiotic, and it came from a fungus on Easter Island. But it soon became apparent that although it works as an antibiotic, it also is an immunosuppressant. It stops things growing, so it can be quite useful for transplants. So it was then used extensively as a post-transplant drug to prevent rejection in highest dose, because it directly interacts with this switch and turns it off. So then it doesn't matter if your TSC1, TSC2 is mutated, you've got a drug that will control it. Everolimus is another, it's a molecule that's very much like sirolimus with a slight change, which is the thing other drug companies do. Once one drug company discovers something, others try and get a molecule that's almost exactly the same, that they can tweak slightly and then patent that. So, the first thing that happened was there were a number of animal models of TS by that time, and they got given rapamycin or sirolimus, and the tumours all shrank. Very, very impressive results. People were a little bit frightened about giving it to humans because we know that the mTOR pathway is necessary in normal cells, both in development and in normal life. But there was already quite a bit of experience for using it in transplant patients, so we knew a bit about safety. So a number of people had experiments, and the first 6 people, 5 and then 6, to have Sarodemus were people with David Friend's patients from Cincinnati, and I think he talked about this particular thing when he came in 2007. And these were people who had had a Sager that was getting bigger, had surgery, but it didn't quite take it all out and it started to grow again. And Sarodemus shrank it and returned to normal. And then he tried stopping and it grew again, and then he put them back on. The same happened with AMLs. Given people with AMLs, Sarodemus, it shrank the AMLs. So that led to a number of more formalised trials, both in the United States. This is a trial from Cincinnati that John Bissler carried out. This is the one we did in the UK, and another one, multi-centre one in the United States, that when you give Sarodemus, the AMLs begin to shrink in most patients. I mean, some do odd things, but mostly it's very useful. However, when you stop the Sarodemus, they start to grow again. So this was stopping after this year. In Tesla, we didn't stop until 2 years, and we had less regrowth, but still some. And there was a mixture in the multi-centre trial. So by then you do 2 things. One, that you could use some mTOR inhibitor fairly safely, and 2, that it worked, and 3, that we couldn't really stop it in the first 2 years. And we don't yet know how long to continue it for. But what we needed was a proper phase 3 study to see whether it was really useful treatment for TS. And the phase 3 study is where you have a group of people and you give a number of the active drug and a number of placebo, and then you compare the side effects in both, because if you have more side effects on the drug than on placebo, then it's probably a drug side effect. But if 40% of people have headaches on both, then the headache's not a side effect, it's just part of the condition. And so Axis 2, which Novartis sponsored, was to look at this kind of safety benefit and long-term use. And there were 118 people recruited. 2/3 went on active treatment at first and 1/3 on placebo. The ones on active treatment, 93% of the AMLs stopped growing or shrunk. In fact, most, 80%. By 6 months it shrunk, and after 6 months it's 90%, and it's getting more. Whereas on placebo, 78% continue to enlarge, and the ones who are getting biggest, fastest swapped to active treatment. And then at the end of the placebo phase, we swapped everyone over to active treatment. Besides that, those who had Sagers, the Sagers shrank, skin improved, a number had improvements in epilepsy. We haven't yet analysed the lung results. And there were some side effects, which I'll tell you about. But it's now 2.5 years. Those people are still on treatment, and they're still doing well. The inclusion criteria are important because that reflects the license that we've got. So for this study, we needed to start with a dose of everolimus that we thought would work, which was 10 milligrams. And also people at greatest risk, because we didn't know whether there would be real problems. So it had to be people over the age of 18 with an AML 3 centimetres or bigger. Because the results were so positive, we've got an early application approved for license in America and Europe. And it's a provisional license, so it's provisional on further continued observation and the results being satisfactory. And it's the same in Australasia, that you need a license before you can get reimbursement. Cost, however, is quite spectacular per patient per year. I think I've converted it right to $1,000.
Yeah.
That's not the full true cost, actually. That's the true cost if you bought it on a private prescription. That's what the company charge you. But each government does a secret deal with the drug company, but they get it at a low rate, probably 1/3 off my contacts tell me, maybe more.
What does that compare to an embolization?
Embolization is much cheaper. short term. So we're trying to do for the UK, we're trying to do some careful cost analyses, but all in all, an embolization is probably about 5,000. But of course, if it doesn't cure the problem, and if it needs to be repeated, and in fact, if it makes things worse because it makes people more likely to develop kidney failure, then it's not going to be an acceptable alternative treatment. And that's why the other data that we're still collecting is so important to work out where the cost-benefit lies. And it's still an argument we've been having with some of our physician colleagues, but most are now convinced by the data. So the international guidelines, which you'll see on ATSS website, as I say, they cover the new criteria for how you diagnose TS, which it's always been a collection of clinical criteria, because you could only pick up the mutation in a small number originally, but now it's about 90% you can find the mutation, and you can tell whether it's pathological from how it correlates with the disease, other people and their parents. And then there's an international database for checking whether any mutation you find is one that's going to cause the disease or just a normal variant. And so in new guidelines, if you have a pathogenic mutation, that's an absolute diagnostic criteria as well. But they also, more importantly, cover what should be done in terms of surveillance. So that will play into kind of what needs to be done in clinic and reimbursement, and also what's known about how best to treat people. For the kidney side of things, the recommendation is that everyone with TS should have an MRI scan every 1 to 3 years. Now, the reason for picking an MRI scan was because in the neurological part of the guidelines, it recommends everyone from diagnosis to early adulthood should have an MRI of the brain to pick up SAGA, so it can be found and treated early if they've got one that's progressively getting bigger. So we felt that, if you're going to have an MRI of the brain, it would be crazy not to do an MRI of the kidney at the same time. In some places that's not a problem, like in America. Obviously, if you're someone that needs a general anaesthetic in order to go in the scanner, that's more of an undertaking, and that's quite a number of people with TS. In Australia, it's a particular problem because you don't get reimbursement for abdominal MRIs, and that's an issue that's being looked at and worked through by the physicians who are kind of worried about it. So as I've been going around talking to physicians here, they've been asked, what about ultrasound? Can't you do an ultrasound instead? The answer is, for most people, you probably can, most of the time. It's nice to have at least one MRI, and because if you do know exactly what, in multiple AMLs, complex picture, if you know exactly what's going on, it makes it much easier to interpret an ultrasound. An MRI is still a little bit more accurate, but an ultrasound every 2 or 3 times, but, you do 2 or 3 years running an ultrasound and then an MRI every 4th year would be a reasonable thing to do. A CT scan is a perfectly acceptable alternative to MRI for working out what's going on, but it carries a dose of radiation. So if you do repeat CT scans, you have lots of radiation, and that the radiation can cause problems. And that's why we didn't recommend CTs. But we sometimes still use it. Sometimes where we can't do MRIs, sometimes when we want to tell if there's any fat in the AML. In the guidelines, we also recommended that everyone should have their kidney function checked once a year and their blood pressure. Kidney function was based on the evidence we'd found. The blood pressure is not based on evidence at all. It's just expert opinion. But kidney specialists are obsessed about blood pressure because over the last 2 decades we found that if you've got a kidney problem and you have your risk of having high blood pressure is 30 to 40% instead of the normal 10%. And if your blood pressure is not controlled, it will make the kidney function get worse quickly. Whereas if you control it, you can completely flatten or remove that risk. So blood pressure is very important. And there's lots of treatment available for blood pressure. Okay. And the other thing, was about treatment. So we recommended that AMLs that are large and centimetres and growing should be treated preemptively to prevent problems. Partly because we want to prevent a problem from that individual AML bleeding, and partly because we want to prevent all the other AMLs growing and then causing kidney failure. So for that reason, on the basis of the ATSS-2 studies, we thought the first-line treatment ought to be an mTOR inhibitor. Other things, of course, could be used if need be, but for someone who has a bleed and is rushed to the emergency room, then it's embolisation is the best immediate treatment. I just wanted a little bit of background perspective. So ATSS-1 was it's similar study to ATSS-2, but it was it was children with growing SAGAs who were recruited. And again, there are 117 people that were recruited to that, and 2/3 put on active treatment, 1/3 on placebo. In that study, half the children already had AMLs in the kidney of at least 1 centimetre or bigger, and many had sort of multiple AMLs and some bigger AMLs. The whole group of people with SAGAs, their average age was 9, but the ones with AMLs were slightly older. Their average age was 12. And so there were 78 on everolimus, 39 on placebo, and in 95% of the people on everolimus, the SAGAs shrunk. And in fact, none of them got bigger, and none of them had surgery. But none of the SAGAs shrunk on placebo. But the SAGAs did, a significant number did enlarge on placebo. And so, again, that was at that 6-month time point, that bit of the study was stopped, and the placebo patients are swapped over to active treatment. And then everolimus in the United States had already had a license for treatment of SAGA on the basis of previous study, and this extended it. Also, 43% of people noted a significant improvement in their skin rash, and it seemed to fluctuate on placebo, but it's been progressively improving on everolimus. But the kidney AMLs, so this is a paper that's about to be published, it's a sub-analysis. These are percent of patients against the time point. And basically on everolimus, those with AMLs, all the AMLs shrunk by 30% or more. Half of them were by more than 50%. And actually, what we were most interested in was stopping them getting bigger. So the fact that not only did none get bigger, that they all shrank, that was a bonus. One patient showed a bit of shrinkage. Some patients appeared to shrink, but they were actually fluctuating on placebo. But as time went on, there was only one who had any kind of significant improvement in their AML. What that means is, this is a group of 12-year-old children on average. So they're not going to get renal. These are people who were they were the 50% who were going to get the severe disease as adults, but they're not going to get it now because they're continuing on everolimus to keep their SAGAs shrunk. So that means renal disease is prevented in them, which is very good news. But what about side effects? So our main worry, and when I talk to doctors, particularly kidney specialists, they worry about side effects because when you treat people after transplantation with mTOR inhibitors, there are quite a lot of side effects. But that's partly because they're a group of people who've been very sick. They've been in kidney failure often, or always. They have other immunosuppression. But in fact, people with TS are much more resistant to side effects. And we were pleasantly surprised that side effects, on the whole, pretty minor. There were 3 patients, or 3 patients in ATSS-2 and a couple in ATSS-1 who had developed an allergy to everolimus, so they couldn't take it. And most people had mouth ulcers at some stage. So because everolimus and sirolimus decreases turnover of normal tissue as well, if you have an operation, it inhibits wound healing, so you have to stop it before the operation and stay, or if you can, and stay off it for at least 2 to 6 weeks after the operation until wounds are healed, and then you can start it again. But the mouth is something that turns over and replaces every day because you wear it away every day. People who are sensitive to this erythemas can develop mouth ulcers. They usually transient, fairly easily treatable, and in those people who had recurrent mouth ulcers, we lowered the dose, and that stopped them coming back. And no one, either XS1 or XS2, stopped the treatment because of mouth ulcers. They didn't need to. About 17% had new acne or worsening acne, which lasted weeks or a few months. But by the time they developed it, particularly the young, more sensitive teenagers, they couldn't care less because their facial rashes were so much better. Their acne they treated with normal acne treatments was not a problem for them, and they didn't want to stop or reduce the tablet. One thing it's a known side effect is cholesterol levels and triglyceride levels can go up on an mTOR inhibitor because it slows down your breakdown of them. So you have to be more careful with the diet, and some people have to go on statins.
Can I just ask you a question around that? Because renal physicians tend to get quite worried about cholesterol as well as blood pressure. And what your thoughts are as far as someone running their cholesterol high, particularly in children?
So high cholesterol will be an increased risk for cardiovascular disease later in life. And obviously the measures to control it will help. All the intervention studies in cholesterol, the ones giving statin, will show marked improvement in outcome if you give a statin lower cholesterol. It's the benefit which accrues is related to the degree of percentage fall of the cholesterol, not to the absolute level. So we do have some absolute levels as target, but actually what the trials tell us is that if you go 20 or 30%, that seems to give from, say, cholesterol of 7 to 5, that seems to give much benefit as if you lower it from 5 to 3, which is reassuring. So we don't know what the long-term outcome will be, but if you're taking the treatment because you have a very good reason to, then cholesterol is something that can be managed in other ways. That wouldn't, in my mind, be a reason to stop that treatment. The kidney specialists are trained to be obsessive about each little figure, of course. They're that big one myself, including blood pressure figures. But blood pressure, again, can be controlled with other treatments quite easily. So the other thing that worries the kidney specialists is protein in the urine. And some people on mTOR inhibitors do develop or increase the amount of protein in their urine. And in other types of kidney disease, the severity of the kidney disease correlates with the amount of protein. And particularly in uncontrolled blood pressure, if the higher the level of protein in the urine, the more the risk. But if you control the blood pressure, it reduces it. I don't think protein in the urine means the same thing in this condition because it's a different mechanism. It's not due to progressing kidney damage. It's due to the basement membrane, the sieves in the kidney, the holes not being quite so tight. So just allowing a bit more through. And in absolute terms, the amount of protein in the urine is fairly trivial. The body can cope and make up more protein to compensate. So I think it's something we need to monitor long term. I don't think it's going to be a problem. What we were worried about mostly was infections, but there's been an increased level of infection, and that's not been shown in either XS1 or XS2. And that may be because there are only 200 odd patients. And certainly there are individuals who seem to have more infections on high doses, and you lower the dose and it gets better. So I think if you have 2,000 or 3,000 people on mTOR, then you will have more infections than the people on the treatment than they would have otherwise.
We had quite a neat sort of study at home because we've got one twin who has tuberous sclerosis, and he's on sirolimus, and definitely he gets sick for a bit longer than his sister, so they always get the same virus. And what might take her 1 or 2 days, he might take 3 or 4 days. He doesn't become acutely unwell, but they just sort of linger around.
Yeah, so that doesn't surprise me because it probably takes the immune system much longer to get going because you're slowing down the speed of its reaction.
That would also be because sirolimus never understands immunosuppressants as well. That possibly mean the body takes longer to fight.
Sorry, I missed the first bit of that. Yeah.
Sirolimus and everolimus, because they're immunosuppressants, and you say it takes your child is sicker for longer.
Yes.
The fact that it's an immunosuppressant.
Yeah, but it doesn't seem to immunosuppress them like it does healthy people. And that's was the fear when people first started using standards that, compared to healthy people who start on they get very immunosuppressed. But definitely would have blood tests done when he's sick, and he mounts a full immune response in his vaccines.
Yeah, I mean, I think the issue turns out that there's quite a wide therapeutic ratio. So every drug that you take has an effect on basic biological processes, otherwise it wouldn't be a drug that works. And what really matters is the window, how much effect it has on the cells you're targeting, be they bacteria or human cells, against the normal cells. And if the normal cells you're just winding down a little bit and can cope, they can cope. And the TS tissue seems to be exquisitely sensitive to an mTOR inhibitor, as it should be, because that's the pathway that makes it a TS cell. Whereas the normal cells can overcome that degree of mTOR inhibition. Wouldn't be the case if you vastly overdose someone, of course, because that would be toxic to normal cells. Sorry, were we going to? No. And then just one other thing. So 7 of the women in the ATSS studies developed amenorrhea. That's their period stopped. And that was due to slowing down of ovarian ovary turnover. Now, in 4 of those, it recovered pretty quickly without any alteration in dose. And in 3, it took up to a year to recover and the periods to come back. So that means there is a small risk, and a small risk of kind of long-term fertility. We know in men after transplantation, if they have sirolimus, that their sperm counts go down. So it does affect fertility to a degree. Interestingly, of course, those 7 women who were taking treatment and amenorrhea, that they were offered the chance to come off the drug, and they will absolutely refuse to stop taking the drug. Their rash is getting better. A couple of their epilepsy had improved. AMLs were shrinking, which they knew. So they said, what's important, doctor? So we kind of listened. The worry in terms of children, of course, is if that's happening in adults, will it delay or perhaps stop sexual maturation in children if you started early enough? So far, it doesn't seem to have happened in anyone that we've been following, particularly in XS1. And there are quite a large number of children who have been prescribed sirolimus or everolimus around the world, and there haven't seemed to be any problems. But we need to very carefully collect all the information and add it together, I think, to track it, just in case.
Is there any effect on seizures? Or any effect of the mTOR inhibitors on seizures or on epilepsy medication?
Yes. Let me tell you about that. That's really exciting. Lamb first. So there was clear evidence that lamb was affected beneficially by mTORs, and then the MILES trial came out. The MILES trial said that if you had moderate lung impairment with lungs that were declining because of lamb, you could completely halt that if you went on sirolimus. But you had to start early enough, because by the time you got quite bad lung damage, it's self-perpetuating. In the MILES trial, they weren't sure. They weren't sure where the balance of risk lay between causing infections, which would make things worse, and inhibiting the LAM process. So they stopped treatment after a year. And as you see, the people on placebo went on deteriorating, but then the people who had stabilised on sirolimus started to deteriorate at the same rate. At the end of 2 years, they analysed the data and they put everyone on sirolimus. And so far, they seem to be stable. There's a study going on with everolimus at the moment, very similar to this. And the results of that haven't been released yet. But Simon Johnson, who's kind of the world-leading lamb expert, is already rewriting the guidelines to put everolimus in as well as sirolimus as a treatment. So I suspect, since he's the leader of this study, that he knows the results and that it's positive. That will results next week. Epilepsy. So in many instances, in individual people, there had been improvement in seizures, people taking sirolimus or everolimus for other reasons. And then David Fran started in Cincinnati giving people sirolimus and everolimus for resistant epilepsy to see if it would work. And then they formally did 2 formal studies. This is the second of the study. This is from David Francis' group. Darcy Kruger is the person who works with him. And they took a group of people with resistant epilepsy, so 30% of people with TS, so 90% have epilepsy, and 30% end up as a resistant epilepsy that 2 or 3 or more drugs doesn't control at all. And that was the group they took. They found that 75% improved. 25% it was a modest improvement, and in 50% it was a very marked improvement. So that's very exciting. That was improved compared to what they'd been like before, so it's a phase 2 study. And there is a phase 3 study coming along, EXIS-3, whereby people with resistant seizures are going to be tried either on active treatment or placebo to see where the balance of risk-free benefit lies, in exactly the same way the other EXIS studies were set up. So that's a worldwide study. There's a centre for that in John Lawson's unit in Sydney. And they're about to start recruiting. There have been 200 people entered the study in Europe already, and the United States will be doing it. So by the time it reports, which is going to be 1 to 2 years, we'll have firm evidence that might lead to a licence for everolimus for seizures. Certainly in animal models, sirolimus and everolimus can be very useful for seizures. To sum up, we know that mTOR inhibitors are good for SAGA, good for AMLs, good for lung, good for skin, and we now know they're good for epilepsy. So that raises the next question: is how soon should you start an mTOR inhibitor? Because if you have an animal model of TS and you start them on sirolimus at birth, they don't get any of the signs of TS compared to the ones who've been started on placebo. So you completely abolish the development of the nasty aspects of TS in animals. And so that would be the really exciting thing to do, is can we eradicate TS as a sort of childhood adult disease by putting people on the right dose of mTOR. And it's getting the balance right, which is the scary thing, of course. It's age 5 or 6, we would have some idea about how badly the kidneys were going to be affected. And if you started preventive treatment, then you could prevent lung disease. You probably prevent or vastly ameliorate the skin rash. It would help for the resistant epilepsy, and it would decrease the risk of sudden death in epilepsy. So that will probably be the first study started.
What about earlier, Chris? Earlier than 5 or 6 years, or is that too? Is that like
in the newborn?
Issues?
The next down. So yes. So if you started at that stage in newborn, before the early severe seizures screws up the development of the brain, which it does, and in animal models, if you have uncontrolled seizures, it causes more brain maldevelopment, and it leads to resistant epilepsy and intellectual impairment and autism in animals, as far as we can tell. But that's quite tricky to pick those up, but certainly. And then if you treat them with sirolimus, it doesn't do that. So it looks very much as if that's probably going to be directly applicable. So you need to give just enough to have that effect on the TS tissue in the newborn child, but not enough that you're going to affect the normal tissues that need it to develop. And it's when we have the courage to do that, because these are things we might prevent. I think we're almost there already. There are 2 studies that go on in Erasmus University in Holland, one in 3-month-olds and one in slightly older 3-year-olds, looking at effects on epilepsy and effects on autism. There is quite a lot of experience individual patients who, from age 1 to age 5 around the world. It's all scattered amongst different studies and different clinicians groups, and we need to pull all that information together and look at not only what the effects, beneficial effects have been, but whether there have been any side effects, and also what the follow-up is. So what we're hoping to do in the UK in 2015 is have a conference on early prevention, and through 2014 contact all TS specialists around the world and say, what data have you got? Let's pool it, let's have a look at it and seriously consider setting this up. I have asked Novartis whether they'd be willing to fund such a study, and they are interested, but they want more safety data. Particularly, they want the results of EXIST-3 first. And that's partly a commercial thing. They need to be able to set up a study that will lead to a license in order to get some of the investment back, because otherwise it will be a money loser for them, and they can't afford to keep losing money. In general, although everything seems very expensive to us, it's not that big bucks for Novartis. They're not going to make much profit. They're going to make huge amounts of profit in oncology because there's so many people. But if you think there's about 1 million people worldwide with TS, probably at least half of those would benefit from taking an mTOR inhibitor, possibly more. But only half of those, only 250,000 people, are going to be in countries that can afford it. That's just 250,000 people. That's not many to sell your drug to. So that informs a commercial company's logic about how they would invest in that particular drug. If there are within Novartis enthusiasts who believe in pushing forward the agenda in TS and trying to get more people on treatment who will benefit. But they're kind of the poor cousins in the oncology division, because they know that the rest of the oncologists will be responsible for making much more profit for the company. So they refer to themselves as the red-headed stepson. And it's one of the reasons I try and encourage them. And their motivation, I think, obviously there's a little bit of commercial motivation for them, but it's mainly altruism. And the fact, of course, if it would be good for the reputation of the company to do this. But right almost at the end. So this is a kind of paradigm. If you look, when doctors are treating people with drugs, they look at kind of the ratio between the benefit and the risk. So it's kind of an arbitrary benefit-risk ratio here, sort of concept slide. And then the stage of the disease. So these could be the stages of kidney disease, which will also correlate to age, because you'll be less numbers of AMLs and smaller AMLs when you're younger. And normally what you would expect is the benefit divided by the risk, or the benefit-risk ratio, improves progressively the worse the disease is, if it's effective throughout all stages of the disease. And that would be normally what doctors are thinking of when they're deciding whether to put someone on treatment. Actually in TS, of course, you start at a high level, because there are other benefits like SAGA and rash and epilepsy. So it's going to be a better look, but it's probably not like that in TS. It might be more like this, that because of all the other co-benefits, there's significant benefits to be had at an earlier stage to prevent the problems getting worse and to prevent too much epilepsy. So that completely alters about when you might think about starting the treatment. And indeed, it might even be like this. The earlier you start, the better the long-term outcome because of the early prevention. So that's the bit we need to research and to study. But if it's like that, then the argument that they're not too bad, we'll wait, won't hold. We won't want to start much earlier. And last slide. So this is us walking along the Inca Trail, raising money for TS research. That's my son, who's a character in his own right. Anyway, so thank you very much. So, anyway.